Let's talk a little bit about combined therapies, weight loss meds, and minimally invasive endoscopic techniques, manejo mixto endoscópico y medicamentoso, resultados, kombinierte Therapien, Medikamente zur Gewichtsverlust und minimalinvasive endoskopische Techniken. Combining weight loss meds to minimally invasive endoscopic techniques or even to bariatric surgery itself is trying to win this tug of war that is finding balance. What is the point of letting a patient lose 40 pounds, 40 kilograms, and just watch him or her regain it all over again? I know it's a hard mission, but I'm willing to fight this chronic, progressive, and yet incurable disease that is obesity. Inside our brains, deep down our hypothalamus on a tiny part called the nucleus stratus solitarius, or simply NTS, apparently lies our body's most relevant secrets regarding eating mechanisms. And here I have to quote Dr. Carol LaRue when he asks us to define obesity. What is obesity anyway? Some of us will begin to enumerate all the obesity-related diseases such as sleep apnea, hypertension, diabetes, joint issues, fatty liver disease, but I have to remind you that those are the symptoms of obesity. Obesity itself is defined by two major points: excess hunger and lack of satiety. Please do keep it in mind because our treatments have to take this definition in order to offer the best solutions we can provide at this point. So incorporate to your minds the study from Polidori in obesity dated 2016. Those guys came up with this weird equation that we don't have to understand. What we do need to remember is that for each kilogram the patient loses, his hunger is increased by 100 calories, but his metabolic basal tax decreases by 30 calories. Crystal clear on how it becomes progressively more difficult to lose and to maintain weight loss. Although we have a few options on the market now that I'll mention briefly, we must understand the importance of long-time treatments. And if we are talking about long time, we should seek for medication with few or not relevant side effects. We could not forget to mention the trial about obesity phenotypes and the one that follows like a spin of that study called Selection of Anti-Obesity Medications Based on Phenotypes Enhances Weight Loss. To summarize this, it classifies 4 types of patients with obesity and the best medical choices in order to achieve better results. But what I'd like you to pay attention is at the very high numbers of mixed groups in our current practices. And just think about this for a moment. Since they fit in more than one group, most of our patients are going to leave our clinics with a bag full of meds because they are emotional eaters, they are binge eaters, they have a body mass fat very high, as most of them are sedentaries, so they are slow burners. They complain of lack of satiety. They can't stay for a long period of time without having a snack. So do they have hungry guts, or is just anxiety leading them to food? Outside a controlled environment, what is actually safe to prescribe until now? If I focus on a slow burner phenotype, am I going to prescribe phentermine at a regular basis? Phentermine is not available in Brazil, but we have a cousin of this drug called sibutramine. And who should not take phentermine or sibutramine? It is listed here, but let's highlight alcoholism, drug abuse, uncontrolled high blood pressure, mild high blood pressure, angina, arrhythmia, chronic heart failure, decreased kidney function, history of stroke, meaning a handful of our patients. So can we prescribe phentermine as often as we wish for? Now, if the person is considered an emotional eater or having the hedonic eating behavior, he or she has the desire to eat to cope with positive or negative emotions. Naltrexone plus bupropion extended release would be selected for this phenotype, as together they modulate appetite, mood, and cravings. But the effect of Contrave on cardiovascular morbidity and mortality has not been established. It is also contraindicated in uncontrolled hypertension, seizure, bulimia, chronic opioid users, patients undergoing discontinuation of alcohol, and several medications such as benzodiazepines. Locazarine was selected for the hungry brain phenotype, as the predominant mechanism of action is to induce satiation by activating receptors in the hypothalamus. Even if we wanted, this med was withdrawn from the market in 2020 since a range of cancer types was reported, including pancreatic, colorectal, and lung cancer. So it no longer can be conceived. Exenatide and liraglutide were the choices for the hungry gut phenotype by the trial. Now we are entering the world of GLP-1 analogs. Comparisons between semaglutide in this study dated 2018 by Andrew Almond show a weight loss of 5.6 kilograms versus 1.9 kilograms in the same period. So if the patient is not being fully assisted by a psychiatrist and a cardiologist, I do not take risks. I choose a GLP-1 analog. GLP-1 analogs have beneficial effects on glycemia. They may be used by diabetic or non-diabetic patients. They showed improvement on cardiovascular health, and their safety is unique. We have mild collateral side effects such as nausea and vomiting. Contraindications are rare, and nowadays we have them as a daily or weekly injection, and very soon we're going to be able to prescribe an oral presentation to our patients. The effects are proportional to dosage and, as I might add, to patients' tolerance. Here's a scale of obesity treatments that I've created and that pinpoints the many moments during the progression of the disease when you can start using weight loss medications. You can begin when patients achieve weight loss plateau. You can use to enhance weight loss in all EBT methods, such as intragastric balloons, endoscopic sleeve gastroplasty, argon plasma coagulation, TOR, and after revisional sleeve gastroplasty. You can use as weight loss maintenance as chronic medications to put obesity into remission, or to prescribe as intermittent use for weight maintenance, preventing escapes from diet routines, as they tend to occur during holidays, trips, or weekends. And I also use GLP-1 analogs to decrease percentage body fat mass on those presenting sarcopenic obesity. Now, let's move on to results per se. This is the very first study regarding the combination of weight loss medications and intragastric balloons. This was a prospective randomized study of 90 patients divided into two groups of 45 matched for sex and body mass index. Balloon plus liraglutide compared to balloon alone. We used the beta balloon, so it was a 6-month follow-up. Liraglutide initiated 1 month after balloon placement. So you can clearly see the difference between groups. BMI of 6.21 in the balloon group versus 7.2 in the liraglutide plus balloon group. Excess weight loss of 71 versus 86, and total body weight loss of 18 versus 22. Now we are going to move on to be talking about the prevention of weight loss after intragastric balloon retrieval. This is very important because doctors can still find themselves a bit lost after intragastric balloon therapies. Can we really rely that our patients have learned their lessons and they are going to keep on the right track? For that study, we used we studied the impact of liraglutide after balloon retrieval. The balloon used this time was SPATZ 3, and we started the medication right after the balloon was retrieved and continued medication therapy for 9 consecutive months. You can ask me, why 9 months? Well, at that point, we didn't have many data regarding long treatments with GLP-1 analogs, and we were not willing to take risks. And we looked at 104 patients for 12 months after balloon retrieval. So they were off meds for the last 3 months before final analysis. So we have the non-user group and the liraglutide group. After 1 year of balloon retrieval, we had non-users regaining an average 0.62 kilograms, and the liraglutide group, we had an average weight loss of 1.61 kilograms, proving that not only medication prevented weight loss regain, but actually provided additional weight loss. This one is a very interesting study that's still being written, although it was presented orally at IFSO Madrid 12/19. It might seem a bit confusing because we ended up comparing 4 different groups. We were using the SPATZ 3 balloon, and we had the chance of performing the upward adjustment or not. So actually we had a group of 40 patients that completed treatment without changing balloon volume, a second group of 53 patients who underwent the upward adjustment, a third group of 35 patients that began using liraglutide 1 month after balloon implant and that used medications for 9 consecutive months, and one last group of 34 patients that underwent both the upward adjustment with the same volume used for the up group that received medications for 9 consecutive months. Weight loss was, as you can realize, more significant between those using liraglutide, either performing or not the upward adjustment. Upward adjustment itself didn't show the results we would expect to see, and we can discuss this some other time. It's a very worthy debate. Now let's move on to endoscopic, sleeve, and gastroplasty plus liraglutide. We're very proud of this study because GIE asked us, Dr. Johanna Bardordin from Johns Hopkins and I, to give an interview due to the importance of those findings. In this perspective, randomized double-blind study, we sorted patients into 2 groups. All of them have had ESG performed using same suturing patterns, same diet and exercising prescriptions. We began liraglutide 1 month after the ESG procedure and had a very close follow-up through the multidisciplinary team. Patients on the liraglutide group used the medications for 11 consecutive months. Just for curiosity, this is still an ongoing study, and very soon we are going to be providing some extra data on. Total body weight loss percentage was 21 in the ESG group and 26 in the ESG plus liraglutide group. Excess weight loss was also very relevant. Now we are moving on my last 2 babies, trials that I have presented just now at DDW 2021. ESG plus semaglutide has already been written and submitted to a very relevant journal. It is very relevant because it shows the potential of turning an endoscopic procedure into a metabolic procedure, as we found outcomes that showed important improvements not only in weight loss. So we had 61 eligible patients divided into 2 groups. 3 patients ceased communications, leaving us with 29 subjects in each group, sham and semaglutide. Patients were followed for 12 months. Semaglutide initiated 1 month after the ESG procedure, same suturing pattern, same diet and exercising for both groups. We found that patients who received semaglutide lost on average 26.7% in the total body weight loss compared to the sham group, which on average lost 19.6% of the total body weight loss. Now we have to pinpoint secondary outcomes. Glycated hemoglobin, also known as HB1AC levels, fell to 0.95 for the semaglutide group and 0.61 for the sham. The semaglutide group also lost 12.7% of the total body fat mass compared to 9% for the sham group. What I'd like you to keep in mind is that bariatric surgery remains the gold standard for significant, sustained weight loss and improvement of metabolic outcomes. However, less than 2% of eligible patients pursue this option. So we have to offer alternative methods to fight obesity. And the last one for now is combining TOR to liraglutide. So we had patients divided into two groups again, and the main findings here are the percentage total body weight loss was 18.7 in the TOR group alone versus 24.3 in the TOR plus liraglutide group. Also, satiety time was 70 minutes in the TOR group versus 111 in the TOR plus liraglutide group. We are still working on the right dosages and treating patients for a longer period of time so we achieve our goals of nadir and to improve fatty liver disease. Let me wrap things up to finish this lecture. If you want to give it a try with phentermine or naltrexone, and if you are having trouble adjusting dosages of GLP-1s, do ask for help. Do share responsibilities because it needs a multidisciplinary approach. Reach out for a cardiologist, for an endocrinologist, maybe a psychiatrist, or maybe all of them together. Keep an eye on your diabetic patients so you can avoid hypoglycemia, especially on those losing weight rapidly. Do not try to skip GLP-1 adaptations by trying a higher dosage at the very beginning. Patients need time to adapt. The organs need time to adapt. Allow yourself to think outside the box. Between 0.5 and 1 milligram of semaglutide, there is 0.75. Don't expect to reach that incredible 2.4 milligrams of semaglutide on the SUSTAIN 6 study because your patients, remember that they underwent endoscopic bariatric treatments. Many of them already have gastroparesis due to the procedure. Avoid at all costs sarcopenia, obesity. There is no success in losing 40 kilograms and still have 50% of body mass fat in their bodies. Identify and treat alcohol abuse. GLP-1s won't do the trick. Think and abuse or metronidazole to help patients leave drinking problems. Discuss with their psychiatrist. And last but not least, do debate cost affairs of long-term medications. Do they fit patients' pockets? Maybe you want to play safe, but your solution don't fit their realities. And what about the futures? Many more molecules and combinations are being tried. Many more are yet to be discovered. And this is what makes this area so exciting nowadays. And do take a look at this study from Dr. Gontran Lopes Nava that shows that ESG does not change levels of GLP-1. And so you must use GLP-1 analogs in order to complete this therapy. Well, thank you. Muchas gracias. Danke schön.